All right, so let's start with a question. Who here is investing in, building in, or using health applications on their mobile device? Anyone? One person? Okay, let's ask it this way. 3 people? All right, that's great. How many of you think health is, I wonder what they're serving us for lunch right after this guy gets done talking? Most of you? Most of you? Some of you? Actually, so there's more of you using health apps than care about lunch, so that's a good segue. So I'm extremely excited to talk with Naomi. Not only do we have a history together in digital health, but what she is doing at Boston Children's Hospital is amazing. And it's going to be hard not to rush right to the punchline, because when you hear about her innovation model and how they're doing mobile, it's a lot more than just healthcare. It's actually how innovation in large organizations is going to work. So let's start by give us a brief overview of what you're doing with innovation at Boston Children.
Thanks, Jeff. Delighted to be here this morning. So I'm the first Chief Innovation Officer at Boston Children's Hospital, and I lead the Innovation Acceleration Program. And our mission is to enhance the innovation culture within Boston Children's. So we're focused on clinical innovation, the delivery of care, and we really want to see how we can make it easier to innovate within the organization. And so we take a 3-pronged approach to our mission. First of all, we're looking to identify unmet innovation opportunities and catalyze work. Second of all, we're supporting strategic innovation initiatives at the institutional level. And then finally, and where I hope we're going to spend some time, is we are thinking about ways to support grassroots innovation. And one of the programs that we have to support grassroots innovation is our Fast Track Innovation in Technology program, or FIT program. And this is actually a competitive award that we offer where anyone in the hospital can apply for a FIT award. And if they win this award, they don't get money. What they get is time with developers on my team who will work with them and build out their new innovative piece of software or their new mobile app. And it's really a team partnership that allows us to very rapidly bring some new solutions into the hospital.
So that's fascinating as an innovation model. And this was the first time Naomi and I caught up, and she was telling me about what they did there. I thought, this has got to be fascinating to folks, because the new currency, certainly in Silicon Valley, as much as it is money, is finding a good iOS developer is probably the hardest thing to do on the planet right now. And what you've done is change that currency from money into, hey, if you're somebody with a great idea, we can help you actually build it. And your incubation model is almost kind of completely opposite of any kind of, whether that's Rock Health or HealthBox or any of the kind of money Rolodex, go build it yourself. So where do you, first of all, everyone in the room would like to know, where did you actually find these developers? And what does that model actually look like? What's the capacity? How does that actually work?
So the developers actually need more skills than just being an iOS developer, because they're developing within our clinical environment, which is incredibly complex. The clinical ecosystem has many, many different clinical systems, whether it's the medical record, the bed management system, the demographics, the lab information systems. We have many systems, and they all have their own unique properties. So we needed someone who could understand the ecosystem and then was able to do the development and really know where to pull the data from, be able to watch out for the HIPAA and privacy and security issues that are part and parcel with any development for the clinical environment. So we actually, our first developer was someone we had in-house that sort of knew the landscape and had some development experience and has been sort of training and learning more about iOS development as he's gone along. And then we hired somebody else, a more junior person who had more skills and a lot of user interface experience, didn't know as much about the clinical environment, and we've been mentoring and tutoring her. So it's a little bit of sort of grow your own, but it's a very particular niche that we're looking for. But the impact of these developers in terms of what they can build is incredible. Because they understand the ecosystem, they can build much more quickly than any developer that would be hired from the outside. In addition, they also build with the idea of how are we going to scale this? What is the architecture? What is the platform that the hospital is already on? So we build a proof of concept, we build a prototype, we test it out, we pilot it. Maybe it'll work, maybe it won't. But if it works, we want to be able to get to scale quickly within the hospital. And all of that is taken into consideration when the development's done by my team.
It's quite amazing, especially, and we'll talk a little bit about commercialization and kind of scaling outside the walls. But let's talk a little bit more about the founder, if you will, in the story, because I think that's also really kind of unique and novel. We're sitting in arguably the heart of Silicon Valley, certainly at least the funding source here on Sand Hill, and we talk a lot about disruption. It's probably one of the most overused words out there, and you're kind of disrupting from within. The part that I find most interesting is who the disruptors actually are. And so talk a little bit about the founders that are coming to you and going after this grant. I don't think it's the traditional kind of people that go through an incubator.
No, it's not. So basically, the award is open to anyone within the hospital. So that means we have doctors, nurses, IT folks, the head of parking applying for these awards.
Wait, the head of parking actually applied? That's
yes,
amazing.
And got one.
Okay, we have to talk about whatever
we can talk about that
at some point, because I did not know that. We're going off script now, because that's amazing.
But the point is, the award's open to anyone in the hospital. These people all have a day job, and they're not interested in leaving their day job. They are applying for these awards because they have problems that need technical solutions, and they have a vision for something that could help their lives run more smoothly, or a better way to help the patients, as the case with the head of parking. His problem was that patients were getting lost in the hospital. We have a huge hospital. They were constantly giving people directions, go past the second building, up 3 floors, take a right, then you'll find the clinic.
Well, it's Boston, so it also refer at least once to Dunkin' Donuts somewhere.
So he wanted to build a mobile app to help navigate within the hospital, a wayfinding app. But anyway, so what's exciting about these solutions that are being proposed is they address real problems that we have. There's a lot of things on the market that people have built because they think we have a problem that we don't have, or it's not a pressing need, so it's not relevant for us. But what we build through our innovation program is really to address the problems we have. And we have a review board that makes the award. We do due diligence on the projects. And one of the things we look for is how important is this and how scalable it is, and will it really matter across the whole hospital?
So you have this situation where you're in the cradle of one of the great education centers in the United States. I mean, you're sitting around not only great clinical organizations like your own and Mass General and so many others, but you've got Harvard and MIT and HBS, and you're churning out talent in that area. It's interesting that rather than turn that lens outside, you turned it inside. What about doctors and their role in the process, particularly? Because again, talk about an area we tend to think of healthcare as fax machines and clipboards and all these things, and we talk about doctors as being entrenched in the way that they do things. Talk about, you've got this community around you that I think most people would probably turn outward to. You turned the lens inward, and talk about doctors and other medical professionals. I'm still fascinated by the head of parking, but let's talk about the doctor side a little bit.
So our clinicians are very busy delivering care in the best possible way they can, but they also encounter a lot of barriers and a lot of challenges.
Sure.
And they are always thinking about, how can my life be better? So one physician that came and applied for an award and won it was a doctor in the emergency department. And she was thinking, look, I've got a mobile device, I've got all this information that's coming to me from the clinical records. Can't I sort of get this together, and can't I use a mobile device for better communication? So she applied for an award, and we created a platform for her, a communication platform called Beeper. And what Beeper does is, first of all, allow the care team that's taking care of a child in the emergency department to send quick messages and notes to each other about the care that they're giving. And then it also allows us to push out clinical results directly to the doctor on the mobile platform through Beeper. And the doctors really have found this incredibly useful for 2 reasons. First of all, it really enhances communication. We have a very large emergency department with over 90 staff, and frankly, everyone does not know everybody, and they don't have time to get to know everybody. They're focusing on the child. So now they have a picture of who's on the care team, they're sending notes, they're communicating, and the communication is really enhanced. And second of all, they're finding that they can get their lab results and the clinical information 28% quicker. So they're very excited about the efficiency gain. We as a hospital want to sort of improve the throughput through the ED, and we figured out with no changes in resources, we probably could see 1,300 more kids a year using this solution.
Oh, that's fascinating.
So we're very excited about how we can make it easier for the doctors. And again, this was a physician who came up with the idea that there's got to be a better way, and there's technology, so help me get there.
So that kind of leads to this, either should there be or is there kind of the Hippocratic Oath of health apps. So if you can actually push 1,300 more children through your hospital, do you feel that there's a business opportunity, an ethical requirement? Like, how do you then commercialize those things if you're finding that kind of output?
Yeah, it's a great question. So, our first goal was really to enhance our efficiency and to improve the care that we've delivered. And as our projects are moving from pilot to internal operationalization and enterprise solution, it's occurred to us that, yes, we probably have an obligation to get this out of the hospital. We actually don't have a strategy for that yet. It's something we're just starting to think about. But there may be licensing opportunities, there may be partnership opportunities. Certainly there's interest from other hospitals when they hear about some of the solutions we built. Another one that's very popular, that's getting a lot of interest from other hospitals, is a patient-oriented solution. It's called My Passport. And it's a mobile app for the iPad for patients that have been admitted to the hospital. And it has 4 features that I think really make it very exciting for the patients and their families to use. The first one is they can get access to their lab results through their iPad. And we've created a very nice user interface that's not just sort of numbers and a line. So that's right away available to them. Second of all, they can see a picture of everybody who's on their care team with their name and their role. Because as an academic medical center, sometimes there's a parade of clinicians and others, students, ancillary staff that come through the hospital room, and it can be very confusing, who just came in and why, and wait, who do I ask my question to? So now in front of them, for their entire duration of the stay, they can see who's come in and who's on their care team. The third feature that we think is very empowering for the patient is we actually provide information on their care plan, what it's going to take for them to be discharged home. So a lot of times parents don't know when they're going to get to take their kids home and what's stopping them or what needs to happen. So now the nurse populates this, and so they know whether it's the fever has to come down, or the catheter has to come out, or the child needs to be able to eat or walk, or whatever it is. Now it's all there, and they can refer back to it. And then finally, the fourth function of My Passport is really a communication function. And so the patients and their families can send questions to the care team, and the care team responds. Because a lot of times you have questions and there's nobody in the room to ask, and maybe you write it down, or maybe you think you're going to remember, and maybe you don't. But now we're really facilitating better communication. So there's a lot of interest in this pilot that we have going in potentially licensing or somehow getting this app into other people's hands and other hospitals.
I can imagine that. So let's, so I'm a huge fan, and you know that, but we're going to shift to a slightly controversial question, which is, what if I can't afford an iPad? I mean, part of the challenge is you're serving, a big metro area in Boston, and I grew up there, and I'm, certainly there are areas of that town where having an iPad is a decision about not to eat for a month, as it would be in any metropolitan area. So are we designing health solutions for the rich? And I don't mean just we, meaning you, but when we think about how mobile works, what's our kind of ethical responsibility to build kind of up and down the access chain? So
for the pilot, which we're in right now, we have purchased iPads, they're dedicated, they're locked down, you can't actually do anything else on them but this. But that's not a scalable solution, given how many kids we see every year. So what we're planning for the enterprise deployment, which is still a ways out, is first of all, we need to port this to any mobile platform. So not just an iPad, but you can use it on any mobile phone. But we recognize it's still, again, there may be an issue that not everyone has a mobile phone, or they didn't bring it with them, or whatever. So we will purchase some iPads that we will give to the families to use while they're in the hospital, and those will come back to us. But this idea that people will just show up with their own mobile devices and use them in the hospital is actually very challenging. It works in lots of other environments, but we're in a highly regulated, secure environment where we have to be concerned about HIPAA and privacy. And so the model that we have right now, we actually have to come up with a new security model to allow people to bring their own devices. This is a whole hot area in healthcare right now, is how do we let people bring their own devices to keep costs down? So it's a challenge that our IT department has taken on. They've pretty much solved, and we think we can move in that direction.
Well, that's really exciting, because I think it's, in the last panel, I agreed with a lot of the things that were said. I think you and I were kind of sharing, I don't want to say a laugh, but kind of the idea that there's consumer and there's enterprise, and then in healthcare, when you have that, it's HIPAA and it's the law, and people either have huge fines or go to jail. So it's a different kind of like losing users is the least of your issues.
Right.
I want to be clear in that case, users, not patients. Losing patients is the biggest issue. And so is that also something that you try to staff up around these teams? Because I think that while everyone knows the words and a few people spell it with 2 P's and a few people put 2 A's, most people know how to say HIPAA and they know it's important. Everyone can reference it, but there's a regulatory expertise I think that also comes with building things in the app. How do you help that, whether it's head of parking or the head of radiology, how do you help those people kind of understand also, to bring this solution, here's all the other things that we have to think about?
So understanding the regulatory environment, understanding the clinical ecosystem, that responsibility really resides with the developers and the project managers and the business analysts on my team. So we don't sort of push that out onto the innovator or even the end user who we spend a lot of time meeting with before the product launches. So we really try to get from them what they would like to see in the solution. And then we come back to them with sort of a reality check, a feasibility check. It's like, we can't do these things for these reasons. We're not going to be developing for 2 years, so you can't have all the features you want. So there's a lot of back and forth, but really the responsibility for all of those issues lives with our team as the developers.
It's an amazing resource. One more question, and then we'll just check if the audience has any questions, and then we can move on. So the other challenge I see is the enterprise market, right? So if I'm Cerner or Epic or any of the big EMR players, you're building beautiful mobile apps to view those things and all of that stuff. And now all of a sudden my customer is building, if I'm them, my customer is building better solutions, or maybe solutions that are on my roadmap further out, and kind of what has the industry's view of the innovation program been? And I mean, I'm sure that to your face they tell you it's great while buying you a bottle of wine or whatever it was the gentleman mentioned earlier. But what is their view? What do you think their perception is? And how has it been to work with industry when in some ways you're kind of innovating because they're not?
Right. So I think that we have been running hard and fast to come up with the solutions that we need. Of course, before we go out of the starting block, we check to make sure that this is not an imminent release from anyone else. And again, to go back to the beeper example, or even my passport in particular, we couldn't find anyone that was doing anything like this.
Right.
I think that from the medical records perspective, the EMR developers, they're probably watching what we're doing, trying to understand what we're doing in terms of new features that we're building. So should they be able to push information out to the mobile devices selectively? Absolutely. Will they get there? Probably pretty soon, but maybe not soon enough for us. And so that's why
we don't have enough time to actually
that's why we're really interested
there may be somebody in the audience who will upset. But,
we want to come up with the solutions because we need them now, and we don't want to wait.
It makes a tremendous amount of sense. Are there any questions that anyone would like to ask Naomi about the innovation program in general, how they attracted developers or built stuff through? Or we've got one or two more questions that I can ask too, but I want to see if anybody else had any questions that they wanted to ask.
There's risk and failure, and I didn't hear much about that, although it sounds like obviously a great idea.
Good question.
Right, so the question is about the role of risk in innovation. So risk and failure are part and parcel with innovation, and it's important for us to set expectations with the innovators that things may not work. We may be able to build their solution, but it may not deliver the results they expect. And so we put a lot of emphasis on metric collection and being clear about what the goal of the project is in the beginning in order to figure out if that's what we actually measured and if it was successful or not. Our board tries really hard to find projects that they think will have high impact. Sometimes projects have to be redone or tweaked because we didn't get it right on the first try or with the first pilot. So it's always on our minds, but if you don't choose things that are risky, then you won't choose things that are innovative.
Great. So I have a follow-up question to that. What is you don't have to tell us who, but if you want to, it might be even better. What was the craziest idea so far that's crossed your desk where you thought, I know this person actually believes this is a problem, but this is just, it's either way beyond what we can do technologically, or it's just so crazy it might just work, but still maybe too risky for the first couple of years of the program, because you're trying to build a reputation and stuff. Was there anything that sticks out to you in the applications where you thought, whew, not that one.
Well, we've gotten some requests that have been way too technical for us to be able to undertake.
Okay.
There are things using new radiology systems or new algorithms to help interpret data, which we don't have the expertise. We're really about building clinical solutions and leveraging what's already there. So that tends to be, they're not necessarily bad ideas, they're just completely beyond the scope. And sometimes we get things when we scope them out, there are 2-3 year development cycles. We say, either you come back with something smaller or we can't do this. So there's a lot of conversation also that happens through the selection process. We start with a lot of applicants. We narrow it down to a group of sort of semi-finalists. We bring them in. We talk with them. Oh, is that what you meant when you wrote that? Oh,
right,
okay. Right. And then we sort of iterate to the ones that we think we actually can do that are feasible and that will be high benefit.
Excellent. I believe there's another question.
So I think it's actually a very cheap way to get some phenomenal solutions into the hospital. To give you an example of a piece of software that we built, it wasn't a mobile app, but the nurses came to us and they requested that we replace the grease boards, the whiteboards that were found on every single floor that tell which patient is in which room and who the doctor is and how to reach them. And they had tried a commercial solution, they'd even installed it, it didn't work, it wasn't helping them. So they went back to the grease boards, which are really great if anyone's bothered to update them lately and if you're standing right in front of them. And they said, please build us a digital smart board that'll help us with this information. So we actually built that for them, and we integrated 4 different clinical systems. We made it available throughout the hospital through the medical record. So now a doctor that's a couple floors down can check before he goes into a patient's room to see if the patient's there. So, this is a huge efficiency gain for the hospital. There's time savings for the nurses that it's going to go back into direct clinical care. There's time savings for the doctors. They may use it for clinical care. They may use it for research. So, that's a little harder to quantify, but our leadership really understands that there's real value coming back to the hospital for this type of solution. With the beeper solution, 1,300 more patients coming through the ED is a huge amount. It's a couple $1 million in revenue for us. So, there it's very easy to turn time into money and show the impact. But we really start out with the metric that either the project should make things more efficient for the doctors, for the nurses, or it should enhance the patient experience. And obviously my passport is an example of that. So we don't have a purely financial ROI in terms of how we measure the products, but we do go into any project making sure that we believe there could be a benefit across one of the dimensions that we're exploring.
That's excellent. Those are both excellent questions. Is there maybe one last question that anyone wants? Here we go, right here in the front. Yeah, please.
There's all these products that people can use now to collect personal health data, like, the upband and different things like that. I mean, how do you think there's going to be opportunity to share that kind of data from a person into an institution when you're delivering clinical services?
So I think there's and I think you're probably maybe Jeff, you take the first crack at this given your new...
I'm itching to answer that question.
Go for it.
I think that it's the big disconnect. So I'm right now wearing a fuel band, an up, a basis, and a Lumovac. So that just makes me strange. But this idea of this kind of personal health, personal sensor thing that's gone on for the last couple of years, often rolled up into quantified self as a concept, has been wildly disconnected from the clinical side of care. And the problem is that the medical organizations, it's not that they don't want to do that. There's 2 things. One, you're never going to flip open any journal and say, well, let's have my congestive heart failure person walk 10,000 steps. So one, there's not a standard of care yet that maps to those things. But also, over the last 3 years for legislation, especially this year, everyone's trying to get to meaningful use and get their EMRs in a place where they're not going to now move from government subsidy to government penalty. So we're still a year or 2 away from that data actually moving into the system. The company I just started, that's one of the big things, actually. And so, and working with the Mayo Clinic to do that, and also making sure we're developing those standards of care to get them out there for people. So we're still a couple of years away from it because of the kind of the distractions going on in the space, but it's certainly a trend that's going in the right direction, I would say.
And one thing I would add, and something that Jeff and I both feel very passionately about, is the effect that telehealth and telemedicine is going to have on healthcare. This is the idea that we're going to deliver care virtually, that care is going to go out to the patient, whether it's they're at home or at work, and really it's not about a face-to-face encounter anymore. But once we are having these virtual encounters at home, we can really expand what the doctor knows about the patient by leveraging digital information that's collected at home, whether it's blood pressure, whether it's weight, heart failure, heart rate, all sorts of information. So I think there's really an opportunity to take some of that data that's out there and these devices and the ability to remotely monitor and use them to enhance the clinical experience. And so that's where I think we're going to start seeing clinical medicine sort of converge with some of this sort of patient self-care and data that they're already tracking for themselves.
So, well, great. Thank you, Naomi, for coming all the way from Boston and this amazing program you put in place in such a small amount of time. And thank you, everybody, for paying attention and listening. Thank you.